Alright, so I'm ready to give the test for the previous year topics questions. 15 questions were there. Ready, set, go. So the image was shown of a upper palpebral conjunctiva. This is the cobblestone appearance, and this sign is known as conjunctival papilla. Now this is a hallmark of allergic conjunctivitis, which can be seen in two important conjunctivitis. One is vernal keratoconjunctivitis and giant papillary conjunctivitis. Giant means when the conjunctiva papilla is more than 1 millimeters papilla. Now you cannot differentiate these two only by this picture. Only by history you can differentiate. If a boy with itching is a hallmark symptom of allergic conjunctivitis, with a thick ropey discharge comes to you and slit lamp is this, then the answer is vernal keratoconjunctivitis. If there is a history of contact lens, then it is a giant papillary conjunctivitis. Now it is a type 1 plus 4 allergic reaction, 1 hypersensitivity is more. So this question is regarding vernal keratoconjunctivitis. It is IgE mediated, which is untrue. Offending contact lens should be removed for giant papillary conjunctivitis, not for this. And this is also known as spring catarrh, but that's a misnomer because it is seen in summers. So answer is, incorrect statement is C, because this is history wise it is vernal keratoconjunctivitis. Now, 2-month-old child with complaint of watering discharge from right eye was brought to the parents. Examination was epiphora means that there is a blockage of the nasolacrimal duct obstruction. Means there is a blockage of the lacrimal pathway. In this, any option which is showing a lacrimal passage blockages, nasolacrimal duct obstruction. The doctor noted epiphora and you could observe discharge on pressing between the nose and eyes, that is known as regurgitation test. So in congenital glaucoma, the patient will have watering but no discharge. Watering, photophobia, big eyes, that is congenital glaucoma. A triad is watering, photophobia, blepharospasm, and Booth-Thalmos sign. Here the answer is epiphora was there, so nasolacrimal duct obstruction. In megalocornea, there is only big eyes, but no symptoms. And congenital cataract, the child will not say anything. The parents will tell about leukocoria, white reflex. So answer is congenital nasolacrimal duct obstruction. The third question was the image question. This is the blue light coming from slit lamp, and whenever a cobalt blue light is used, fluorescein dye is used, and this is a dendritic ulcer. The ends are swollen like knobs, that is classical of epithelium herpes simplex dendritic ulcer, causing the involving the epithelium of the cornea. Orange color dye is a fluorescent dye is used under cobalt blue, that is true. Diagnosis is this, is true. Treatment is topical acyclovir 5 times a day, is true. Adjuvant treatment is, main treatment is topical acyclovir 5 times a day. Adjuvant is to decrease pain, that is by cycloplegics, not myotics. That is the answer over here. And if you give topical steroid over here, what will happen? The ulcer will spread, lead to geographic ulcer. Now herpes zoster will have a pseudodendrite, means that ends are tapering ends, but that picture won't be asked in the PG exam. So answer here is D. Okay, so this is the image showing the upper eyelid defect. This is a structural defect of eyelid tissue that is known as a coloboma. This is eyelid coloboma. So you have to remember, eyeball colobomas are formed due to failure of closure of embryonic fissure, like iris, lens, retina, opticus coloboma, and they are always inferior because eyeball coloboma, the fissure, embryonic fissure is present inferior. Eyelid coloboma is formed by failure of eyelid development. That can be in upper, lower eyelid, like in this. Corneal exposure is an important complication, it's a previous question as well. But if the Bell's phenomena is high, Bell's phenomena means 3 and 7 thumbs are involved. When the eye closes, the eyeball goes up and out. So if the Bell's phenomena is poor, then the chance of exposure of cornea are more. And this is associated with systemic condition like golden Haas syndromes, can be associated with dermoids as well, various syndromes. So this is wrong. It is not formed by failure of embryonic fissure, it is formed by failure of eyelid development. So these are retinoscopic values. A 0 means the rays in vertical axis are focused on the retina. -4 means in front of the retina. This is simple myopic astigmatism. And -4 is in front, means that axis is more steeper axis. Means the corneal curvature of this axis is more. and this is known as against the rule astigmatism, not with the rule astigmatism. So that is wrong. Vertical axis is flatter, yes. Simple myopic, yes. Astigmatism, corneal curvature of horizontal is more. Corneal curvature is more means the cornea converging power of horizontal is more means, for example, normal cornea converging power is 44 diopters. So vertical will be 44. For example, two are, one is 44, one is 47. So which will be 47, which is matching this question? More cornea converging power. Horizontal is more cornea converging power. It is more than 44, 45, 46, 47. This is less cornea converging power. That is maybe 44 less than that. Means this is the cornea converging power is more. That's why it is more steeper axis, and that is focused more in front. Simple myopic astigmatism. Against the rule is the answer over here, not with the rule. D is the answer. Now, 70-year-old diabetic patient where retina was evaluated. There were retina hemorrhages and new vessels on the optic disc means it is a proliferative stage of diabetic retinopathy. Age 2. Angiography in diabetic retinopathy, only two signs are hyperfluorescent. They will leak the dye. One is microaneurysms and new vessels. Because there are abnormal vessels, new vessels, there will leak the dye, that is hyperfluorescence. And new vessels are above the retina. They are not intraretinal. Intraretinal is intraretinal microvascular abnormalities. That is the answer over here. And management of PDR is pan-retinal photocoagulation. So new vessels are above the retinal tissue. That's why in fibrous tissue they pull the retina upwards, causing tractional retinal detachment. Young patient, red painful eyes, 30 mm Hg, anterior chamber is deep, small irregular pupil, history of back stiffness. Back stiffness, red painful eyes, pressure is high, small irregular pupil means anterior uveitis having synechiae is there. Deep anterior chamber. Ankylosing spondylitis is the answer over here. That is example of anterior non-granulomatous uveitis. Redness is due to, that is correct. Pain can be relieved by psychologics because here also there is ciliary body spasm. Adjuvant treatment is psychologic. The main treatment is topical steroids. Adjuvant is cycloplegics, but IOP here is raised. Deep AC I am giving. Deep AC means the angles are open. Because of posterior synechiae, there is deep anterior chamber. And why the intraocular pressure is high? Because the inflammatory cells are blocking the meshwork, causing raised IOP by secondary open angle mechanism, not closed angle mechanism. So some words are very, very important in the exam which you have to take care. Now this picture was a previous year question. This is a diffuse picture. This is the cataract, and you can see this. There is the shadow of the iris on the lens. Means this is immature senile cataract. Phacoemulsification is done. Old patient, decreasing vision. Entire lens is not involved. That is in mature senile cataract. That's why iris shadow is seen over here. Similar cataract can be seen in diabetic mellitus type 2, not 1. Type 1 is snowflake cataract, that is insulin dependent. So that is immature senile cataract because this is the iris shadow which you can see. Iris shadow test is positive only in immature senile cataract, not in mature senile cataract. Now, whenever visual field is given to you, it is taken as a patient's view. So this is the right visual field, this is left visual field, this is you are the patient means left homonymous hemianopia. Means the patient cannot see completely from the left side. He will complain when he says he cannot see completely from right eyes. That is right anopia in right optic nerve damage. He cannot see temporal side from both eyes. That is bitemporal hemianopia and optic chiasma damage. That is answer. Cannot see from the left side from both eyes. That is left homonymous hemianopia can be seen in right optic tract lesions. Now patient presented with decreasing far vision, but he now says he can read the newspaper better. That is the second side phenomena of a nuclear sclerosis patient. Central lens shows changes, that is nuclear sclerosis, not nuclear cataract. Because if it is a nuclear cataract, the rays will not go behind. Far and near vision both will decrease. The best corrected vision was 6.6. Patient is of old age, yes. There is not axial myopia, there is index myopia. Refractive index of the center is increasing. That's why the rays are focused in front, causing index myopia. There is nuclear sclerosis, and he is advised to continue the glasses. Please, typo errors, please ignore because I use mobile sometimes, and I'm getting old now. So, answer is index myopia. ICRS, intracorneal ring segments. That is done in keratoconus, non-progressive keratoconus to stabilize the cornea. That is ICRS. Also, other name is intacs, intracorneal segments. Both are same thing, made up of PMMA inside the stroma of the cornea to stabilize the cornea. Keratoconus is an important topic. Now, complicated cataract surgery, surgeon accidentally damaged the uvea, post-op patient presents with pain, no perception of light. Cornea is involved. If cornea infiltrates are there, endophthalmitis is ruled out. Panophthalmitis means all the layers are involved, involving cornea and sclera. In endophthalmitis, cornea and sclera are not involved. So cornea infiltrates, no perception. Ophthalmoplegia means difficulty of eyeball movements, because if sclera is involved, all the extraocular muscles are attached with the sclera, there is ophthalmoplegia. Pus fill antechamber and vitritis can be seen in endophthalmitis as well. But cornea sclera involved goes in favor of panophthalmitis. There is toxic anterior segment syndrome. Only anterior segment is having problem, vitreous is not involved. And sympathetic ophthalmia is due to penetrating injury. The other eye has type 4 hypersensitive reaction, that is sympathetic ophthalmia, and there is no history of this. So answer is panophthalmitis. Answer should be systemic steroids. But if it is a no perception of light, painful blind eye, then evisceration is done. Enucleation is contraindicated because of chance of spread of the infection. Now this is the eyeball. When the eyeball is abducted to 23 degrees, it gets aligned to the pull of the SR and IR muscle. In this position, SR is a pure elevator, IR is a pure depressor. Similarly, eyeball gets aligned to 51 degrees in adducted position. In this position, it gets aligned to SO and IO. SO is a pure depressor and IIO is a pure elevator. Here the answer is X and Y muscles are superior rectus and inferior rectus. That's why which muscle is a pure elevator in abducted position of the eye? Answer is SR. Alright, the 14th question is a diffuse picture. A and B both are lens. A is the cortex area, B is the nucleus area, because the color is changing. Now this is in an old patient. This is hypermature Morgagnian cataract. The cortex dissolves, the nucleus sinks to the bottom. Now this, when the cataract advances, the lens shrinks. If the lens shrinks, the antechamber is already deep, not shallow. That's the answer. A is the cortex, B has increased sclerosis, that is nucleus sclerosis increased, color is changing, and it can lead to phacolytic glaucoma because lens proteins can come out and block the trabecular meshwork, causing secondary open angle glaucoma, that is phacolytic glaucoma, also known as lens protein glaucoma. And the last question, a cardiac patient. Now this is the left image showing a diffuse edema of the retina with a central red. This is a cherry red spot that is seen in central retinal artery occlusion, because the cardiac patient coming with erythemas, embolus can block the central retinal artery. The following image was seen. This is central retinal artery, not vein occlusion. First step is to remove the embolus within 90 minutes by oculodistal massage. If that doesn't work, then inhalation of carbogen can be given. If that doesn't work, it is seen in studies to decrease the IOP, that will dilate the vessel. Fovea is not involved, fovea is spared. In cherry red spot, red is normal because the maximum edema is the ganglionic layer of the retina, which is absent in the fovea. So fovea is spared. Fovea is involved in bull's maculopathy due to chloroquine. So this is central retinal artery occlusion, not vein occlusion. I've seen the result. I've seen many people done very good, and I hope you will do. I'm not repeat the mistakes which you have done. One or two questions you have done some mistakes, very easy questions, but still you have done mistakes. So aim was so that the practice of these questions was so that you don't make such mistakes in the main exam. I hope you'll get all the 10 questions correct in the main exam. Best wishes.